In my last class on Meniere's disease, I discussed about what all things, the etiopathogenesis, the clinical features, differential diagnosis, investigations and the treatment. In the treatment part, I discussed mainly on the about the medicines. What were the medicines? Yes. Just remember that mainly divided into the general measures for the acute phase and for the chronic phase, isn't it? So around 10 to 20% of the patients will not respond to maximal medical therapy. So for them, we have to give surgery as a treatment. So can you tell me what is the surgery of choice for endolymphatic eye drops? We know this is the system, the endolymphatic system get dilated, or there is an eye drops of the endolymphatic system, so that the patient is having severe vertigo, tinnitus and sensorineural hearing loss. The whole membranous labyrinth is default, isn't it? So what will be the treatment of choice, the surgery of choice? No doubt it is complete removal, isn't it? So ablation or destruction of the labyrinth. If you do that, what will happen? There will be complete loss of the vestibular as well as the cochlear component, isn't it? So the vertigo as well as the hearing will go. There will be complete loss of the cochlear as well as the vestibular function. That is not appreciable or appropriate for patients. So there comes a patient selection also, and there is no one standard procedure which will uniformly control vertigo in all the patients. There is no one standard procedure. It is depending on. So how will you how will you select the surgery? The choice is dictated by a number of factors. That is, one is the degree of disability caused by the vertigo, and second important one is the status of hearing. If there is serviceable hearing, we have to preserve that. What is the serviceable hearing? Serviceable hearing means minimum accepted definition is minimum 60 dB, and the speech discrimination score more than 50%. So if the hearing loss is more than 60 dB and the speech discrimination score is less than 50%, we can tell that there is no serviceable hearing. Then in that case we can very well think of removing the cochlear part also. But if there is a serviceable hearing, we have to preserve hearing. Then, so I think the degree of disability caused by vertigo, then the status of hearing, then the age of the patient, then if there is any associated comorbid medical conditions. We have to think of the likelihood of vestibular compensation after surgery also. And the one important thing you have to consider is in the case of an only hearing ear. Actually, it is considered under a contraindication for surgery, which is an only hearing ear. There are a vast array of surgeries described starting from as early as 1877, when it was first reported by Gowers, a surgeon called Gowers. He reported results of blistering the skin behind. There were so many procedures, so many papers, so many research studies, evidences are there. But for undergraduate and postgraduate purpose, we can divide this into those which preserve hearing and those which destruct hearing. Okay. So we can divide this into preservation of hearing, okay, and hearing hearing yes, hearing no. And this part is which one? Labyrinth. Labyrinthine function. Again, yes and no. Okay. can divide this into like this. So what are the conditions, what are the surgeries in where the hearing is preserved and also the labyrinthine function is also preserved. Both are preserved, hearing as well as labyrinthine function preserved. Can you tell me which part? The basic pathology of Meniere's is, what is that? It is the overproduction of the endolymph. So if we can remove or we can remove the excess of endolymph, then the whole problem will come down, isn't it? The whole complaint will be relieved. So all this part is kept under a shell, under a bony shell or a bony labyrinth, except this outpouching. What is this? This is the endolymphatic duct and this is the endolymphatic sac, isn't it? So this part is out. Endolymphatic, where is this endolymphatic sac located? Endolymphatic sac is located on the posterior wall of the petrous bone. So we can access it through a mastoidectomy, isn't it? So this part is easy to access. So if we do some surgeries on this part, both these will be preserved. So this labyrinthine function as well as the hearing part will be preserved. So all these surgeries on the endolymphatic sac is supposed to preserve both hearing and the labyrinthine function. So surgeries on the endolymphatic sac. Endolymphatic sac surgeries. So endolymphatic sac surgeries, actually the results are very good. Patient will get 70% of the patients will get a relief of vertigo, immediate relief, and 20 to 30% improvement of tinnitus will be there, and hearing is preserved 100%, preserved. There is no deterioration. There will not be any deterioration of hearing, and in 30% of the cases, actually there will be an improvement of hearing. So the results of endolymphatic sac surgery: 70% of relief of vertigo, 25 to 30% relief of tinnitus, and hearing preserved completely, and in some 30% there is a reported improvement of hearing. And more than in later, this is an immediate result I told, and in long term also more than 55% of the patient will not have an recurrence of vertigo. They won't any attack of vertigo at all. Regarding surgeries of the endolymphatic sac, what is the approach? The easiest approach, as I already told, this endolymphatic sac is situated on the posterior wall of the petrous bone. So the easiest approach is through a mastoidectomy approach. And regarding the steps of mastoidectomy, that I will tell you later during surgeries on mastoid. Now this is a postoral William-Weil's incision. Extended incision can also be approached, and you will open the, this is a lying patient, this is anterior, posterior, superior and tip apex. Okay. So when you open the mastoid, the first landmark will be the lateral sinus. Here will come the bulge of lateral sinus, and then you drill anterior to that, you will enter the mastoid andrum. So mastoid andrum is the second landmark, and here comes the adytus. The adytus will be somewhere here, and medial to the adytus you will get the lateral semicircular canal, which is the third landmark. Almost here comes your lateral semicircular canal. Okay, so the third landmark is a lateral semicircular canal, and just between the lateral semicircular canal and the lateral sinus, posterior to lateral semicircular canal comes your posterior semicircular canal. Okay. This next, after that, after identification of the lateral semicircular canal, go posteriorly. In between the lateral sinus and the anterior wall comes the posterior semicircular canal. So after drill in the posterior semicircular canal, then it is a identifying landmark for the endolymphatic sac. So usually this endolymphatic sac will be, there is one line which is called the Donaldson line. Donaldson line is usually goes parallel to the lateral semicircular canal and intersecting the posterior canal. This is the Donaldson line. Donaldson line. And that is explained along with my class on anatomy of inner ear. Donaldson line. Okay. So inferior to the Donaldson line lies the endolymphatic sac. This will be the endolymphatic sac. Okay. So first landmark is a lateral sinus. Next is anterior to that you identify the antrum and find out the adductus, which is the second landmark. And after identifying the adductus, identify the lateral semicircular canal, which is the third landmark. And then posterior to that comes the posterior semicircular canal. And just posterior and inferior to the posterior semicircular canal lies endolymphatic sac. So in the classical Portman procedure, it is the Portman procedure is what we are following, Portman, classical one. In Portman procedure, classical Portman procedure, we make an opening in the outer wall of the, this is the outer wall, and towards the subarachnoid space comes the inner wall. So on the outer wall of the endolymphatic sac, an opening is put for drainage of the endolymph. Okay, beaver's blade is used for that, and this is the classical Portman, and we put a gel foam in between, and then this cavity is closed, or we can obliterate the mastoid cavity using a muscle grafting, and the wound is closed in layers, usually in 2 layers. So that is a classical Portman, and there are so many variations. Modification. One such modification is by Shambo. Shambo just put a temporalis muscle over this. He sutured a temporalis muscle, and thinking that this revascularization of that area will cause drainage of excess of endolymph. So Shambo's modification using a temporalis muscle, suturing with a temporalis muscle. And another modification, important modification is by House. House actually put a shunting with a subarachnoid space. He opened the outer wall also of the endolymphatic sac. He opened the inner wall and then opened the outer wall. So the inner wall and the outer wall are opened. If the outer wall is open, there will be a communication with the subarachnoid space. Then what did he do? He did a flanged Teflon tube in between this and the subarachnoid space. On the outer wall, he put a flanged Teflon tube is put, and that is sutured to the outer wall, so that there is a permanent communication with the subarachnoid space. That is the House modification. He put a flanged Teflon tube is placed on the outer wall, creating a fistulous tract between the endolymphatic sac and the subarachnoid space. And another modification, there are so many people, mainly the Hasegawa and Naito, and then there was Morrison's modification. Actually, Morrison put a polyethylene tube. Instead of this flanged Teflon tube, he put a polyethylene tube in that, and then again there was Arenberg. Arenberg is the one who put a valve, and this valve was implanted into the sac. Arenberg. It was Arenberg. Actually, in glaucoma surgery, we put a valve we use valve in case of ophthalmology. And this Arenberg, similar to a valve, was implanted into the endolymphatic sac, and again for the drainage, a one-sided valve was implanted. So that will facilitate drainage of this endolymph into the subarachnoid space. So these are the surgeries on endolymphatic sac. The classical one first described by Portman. Later there was Chambeau's modification by putting a temporalis muscle or suturing a temporalis muscle into the endolymphatic sac. Then House used an flanged Teflon tubing, and then Arenberg, he put a valve is implanted into the sac, and there was also modification by Morrison, who put a polyethylene tubing, and also there is Hasegawa and Naito with the, actually they all made a fistula into the subarachnoid space. Okay, so this is regarding the surgeries on endolymphatic sac. And there are some technical problems. Usually these complications are comparatively less in a case of endolymphatic sac surgery because it is very easy to approach, and the usual complications of mastoidectomy is there, but there is no complication which is specific for endolymphatic sac surgery. But some cases there are some, we will meet across some technical problems. One is a difficult access to the endolymphatic sac. In that case, when we open the mastoid, this view will be, the approach or the view to the endolymphatic sac will be very difficult. So when we open this, all this lateral sinus will bulge towards the anterior wall. So even if we tilt the head of the patient or we tilt the operative microscope, it will be very difficult to identify the location of the endolymphatic sac. In that case, you have to do what comes here? Here comes the external auditory canal. So remove a piece of external auditory canal so that the easy visualization of that area, and after surgery then reconstruct the external auditory canal, posterior wall of the external auditory canal. Okay, so one is difficult access. Then second one becomes a lack of space between the lateral semicircular canal and the this lateral sinus and the posterior canal. Here, this part, this will be like this. So there won't be any space between them. In that case, you use the maximum smallest drill as possible. Okay, there's no other way for this because this posterior wall will be so much near to the posterior canal. Okay, so in that case, the only thing we can do is we are using the smallest size drill can be used. And then another difficulty comes is an opening of the lateral sinus. Inadvertent opening, accidental opening of the lateral sinus causing a very severe bleeding. So that no much problem. You obliterate that with gel foam or and put a graft over that. Control bleeding. And another important one is accidental opening of the posterior semicircular canal. Definitely the patient, if you open the posterior canal, what will happen? The patient will be deaf. There will be complete loss of hearing. So at any cost, remember not to open the posterior semicircular canal. Okay. And another one is opening of the dura. Opening of the dura or the opening of the lateral sinus is not much a problem. We can repair that. But if you open the posterior semicircular canal, that is the end of hearing for the patient. So that has to be highly cautioned. So that is about regarding the surgeries on the endolymphatic sac. And here another, we are telling about the preservation procedures with preservation of hearing as well as preservation of the labyrinthine function. So there are some more procedures on other ear structures. Other than this endolymphatic sac, some other procedures. So surgeries on other ear structures. One is putting a grommet or a ventilation tube into the ear on the tympanic membrane. Because there is evidence that this Meniere is usually associated with pressure changes in the middle ear. So by putting a ventilation tube or a grommet insertion of this, there is improvement in vertigo. Okay, so a grommet or a ventilation tube. And second one is osmotic therapy. What is that osmotic therapy? There are two methods of osmotic therapy. One is by Arslan. Okay, Arslan. He put a crystalline salt into the round window. Here comes the round window. So transcanal, after elevating an tympanomeatal flap, he introduced a crystalline salt over the round window. So this it comes as an osmotic therapy. And second one is called cochlear dialysis, usually asked as short note. Cochlear dialysis by Morrison. What is this cochlear dialysis? It is hyperosmolar perfusion of the scala tympani using mannitol. Right? So for the scala tympani, we introduce perfusion of the scala tympani using mannitol is called the cochlear dialysis. So prepare about cochlear dialysis. And third is Fick and Cody tack procedure, right? I'll write it here. Fick and Cody tack. What is that actually? We are creating a fistula in the saccule. Okay. This is oval window, and immediately beneath the oval window comes the saccule. Here comes a fistula into the saccule through the oval window. So this both Fick as well as a Cody tack procedure is creating a fistula into the saccule through the oval window. But this procedure is abandoned because there is high chance of hearing loss, either immediate or later on. Right? And in Fick, what did Fick do? Fick directly manipulated the saccule through the oval window. Okay, using a pick. That is what Fick do. He directly manipulated the saccule with a pick via this oval window. And what is Cody do? Cody introduced a tack. Okay, Cody. That is why it is called Cody's tack procedure. And he very sharp 1.5 millimeter a tack is introduced through the stapedial foot plate. Okay, through the foot plate he introduced that. So Fick using a pick and Cody used a tack via the stapedial foot plate, but both these are abandoned because of chance of hearing loss. So here the third comes the Fick and Cody, and the fourth one is there. What is that? Cochleosacculotomy.